So thank you for tuning in today. This is my presentation titled Proton Pump Inhibitors in Infants and Children, Re-Optimizing Treatment. Today's presentation was designed as a plenary session for the Alberta Children's Hospital Pediatric Update Conference in 2016, and I gave this presentation a few days ago on May 6th. So I thank them for inviting me to give that presentation, which allowed me to do the review of the literature and put this presentation together. Not only did I perform that literature review to help inform the advice, opinions, recommendations that will come out of the talk, however, I also viewed a recent update of this topic by a variety of experts in the field that was given via the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition, or NASPGHAN. As part of that plenary session, I had to give a disclosure slide, and I think it's equally appropriate when I be talking about medications in an online open forum. So really I have none. I have no interest in any company that currently distributes or manufactures proton pump inhibitors. So by the end of this presentation, I hope that you'll first be able to identify pediatric conditions where the use of proton pump inhibitors is advised, and I'm going to compare that to the approved indications by Health Canada and the FDA. I will then spend most of the time discussing an approach to the judicious use of proton pump inhibitors in infants and young children so that you're left with some grounds for justifying the use, as well as how it can be used as a trial, and what endpoints you may be looking at and how you may stop the trial. I will quickly review some of the evidence regarding potential risks of the medication, particularly over a long-term use, which is often a concern and a rightful one of parents of children who are on these medications, and particularly with a view towards some of the recent literature in the last few years that has come out and provided some further insight. So this slide is a recently updated graphic provided through either Medicare or Medicaid, I can't remember, but you can look at the website for clarification. In any case, it's a nice summary of the recent FDA-approved pediatric indications for PPI use. And there are a few take-home messages from this slide. The first is that there are really only two approved indications for the use of PPIs in pediatrics, and they both relate to reflux. So you see the two colors representing symptomatic gastroesophageal reflux disease and the healing of EE, which is not to be confused with EOE or eosinophilic esophagitis. This is referring to erosive esophagitis, which is the endoscopic features of inflammation or injury that are presumed to be due to reflux. And you can see here that the 5 most common generic used PPIs in pediatrics are listed here, and that there is evidence for the use of these medications in pediatrics, which come from randomized controlled trials for the most part, usually comparing a PPI with placebo, and usually conducted in patients over 1. Now there are some studies, actually quite a few studies, that incorporate everyone from the ages of 1 to 11, or from 1 to 3, or from 5 to 11, or from 12 and beyond. And this can be considered a positive or a negative, depending how you look at it. I do think that patients who are 1 year of age who have reflux esophagitis or reflux related symptoms are probably quite different. However, we do take it for what it is, and we also have to understand that quite a few of these trials have been have been supported by the drug companies. So not to assume bias, but to just take that into account. But just to remember that these were supported by evidence for the most part from trials in pediatrics. There's also a presumption that for improvement of symptoms of reflux disease, the patients older the age of 1 are more reliable in reporting symptoms, but as we'll talk about later, that's not always the case, and in fact, patients up to 8 or even 11 years of age, the reported symptoms don't always align with the more objective findings of endoscopy or impedance and pH studies of the esophagus. The indications are often also listed for short-term treatment of symptomatic gastroesophageal reflux disease and the healing of erosive esophagitis. However, that again is based on the studies, looking more for the short-term use, but not extending the trials longer. And so the long-term safety and efficacy data is not quite there for pediatrics. The last quick messages from the slide are that, as you can see, most of the drugs are approved from the ages of 1 to 17 inclusive. However, pantoprazole is the only one not approved for ages less than 5, and only esomeprazole is FDA approved for patients younger than a year of age. And you can see the star saying that treatment may begin as early as 1 month of age for this indication, again based on a study in the infant population. You'll also notice here that dexlansoprazole, which is another commonly used generic medication in adults, is not approved for use in pediatrics. So what about Canada? Well, the interesting thing is that at present, from what I can gather from the drug product database, the only 2 medications approved for use in pediatrics are esomeprazole and lansoprazole. With respect to esomeprazole, the indication is extremely vague and says the treatment for conditions where a reduction in gastric acid is required. Lansoprazole, however, has a more defined approved indication in pediatrics for the symptomatic relief of gastroesophageal reflux disease, as well as the healing of erosive esophagitis, and in that case in particular, the indication was listed as short-term treatment for less than 12 weeks duration, again because of the lack of long-term efficacy and safety data. So in comparison to the other PPIs listed and approved by the FDA, it specifically says in the label indications that safety and effectiveness in children have not been established, and thus there are no approved indications. If I have to be honest, again without any interest, I do not see a reason why one of these PPIs would be approved based on the current evidence and not other. In reality, this is not always the case, and we don't always follow the approved indications, but we do have to justify their use. And so what I've tried to do here is list some of the off-label uses in pediatrics where treatment is generally recommended in spite of there not being the specific approval by the drug regulatory agencies. And usually the justification for these, as we'll see, is because of adult data, which we feel can reasonably be extrapolated to pediatrics, and for indications where there's a potential for great benefit and often defined duration of treatment is recommended, such the concerns about long-term risk of the medication would be minimal, if not nil. So a nice example of that is Helicobacter pylori eradication. We have great evidence in adults that it's useful as part of a triple therapy or quadruple therapy strategy. There's no reason to suspect otherwise in pediatrics, and so it is recommended. For upper gastrointestinal bleeding or for the healing of gastroduodenal ulcers, similar rationale is used, although I would argue that the evidence is not as clear in adults, specifically with respect to that pre-analysis that looked at the use of these medications for acute bleeding and found 6 randomized controlled trials of over 2,000 patients in adulthood, and the main findings were that it may reduce the risk of stigmata of recent hemorrhage on endoscopy and need for therapeutic intervention, however, had no benefit in mortality, rebleeding, surgery for recurrent or persistent bleeding, or the need for transfusion. However, the causes for upper gastrointestinal bleeding in pediatrics do differ substantially from those of adulthood, and again, the thought is that some of them do respond very well to PPIs, and therefore the risk-benefit ratio would favor a trial even without an obvious trial supporting its evidence. With respect to prophylaxis for NSAID or non-steroidal anti-inflammatory drug-induced gastroduodenal ulcers, I believe this is probably based on the systematic review in adults, which showed the benefits of use in prevention of ulcers in patients who are using NSAIDs for indication that for longer than 4 weeks. And when PPIs were compared with placebo, it significantly reduced the risk of ulcers in both the gastric and duodenal regions, as well as the risk of bleeding or symptomatic ulcers in one study, as well as symptoms of dyspepsia. There's also a study that showed that it significantly reduced the risk of endoscopic duodenal ulcers compared to ranitidine or a antihistamine receptor blocker. But again, it could be argued that the use of NSAIDs in pediatric patients may be for different reasons, and we may not see these benefits in a larger scale when assessed in pediatrics. However, again, the balance of evidence would suggest that it would be a reasonable option. And the current recommendations are that if a patient is being suspected for eosinophilic esophagitis, that if they are currently on a PPI, to continue use, and that would be often for the case of heartburn, being a symptom and worrying about gastroesophageal reflux disease. However, if the patient is currently not on a PPI, it is not recommended necessarily to start a medication prior to the endoscopy. However, if these findings are then found, then a PPI would often be considered to be used in a high-dose fashion for a period of 48 weeks prior to a assessment and decision about whether or not there is some responsiveness to PPIs.